Okay, welcome everybody to this BFest BBA BAPRAS and Research Africa webinar. We're just going to allow a moment or two for you to all join, and then we'll start with a minute of housekeeping, and then I'll pass over to Stuart Watson, who will be introducing this session. Just give it another minute or so to allow people to join as the IT allows you to. Great. Okay.
Hello, everybody. Is everything going okay with everybody?
Okay. Great. So welcome everybody to this webinar. Just before I pass over to Mr. Watson to officially introduce you to it, just a couple of housekeeping things as usual with all these webinars. If you'd like to use the Q&A function for any of your questions, we've got an option to answer them live as well as in writing, so we'll write back to you. So there'll be a couple of different ways they'll get answered. Many of the questions will be answered live during the session, so do keep an eye out. In terms of certificates of attendance, we usually send those out within a couple of weeks after the event, once we've received your feedback. So don't forget to fill in your feedback. And on that note, I'm going to pass you over to Stuart Watson to get things going. Stuart.
So welcome everyone. My name is Stuart Watson. I'm a burn surgeon from Glasgow in Scotland in the United Kingdom. And I'm welcoming you on behalf of the British Burns Association, British Association of Plastic Reconstructive and Aesthetic Surgeons, and in particular, two charitable groups called BFirst and Research Africa, who have set up a series of educational webinars, which are primarily directed at surgeons and other colleagues from multidisciplinary professions working in burn care in relatively limited resource settings around the world. So I'm very excited for this afternoon because we invited a group of colleagues whom you see on the screen in front of you from around the world. And these are colleagues who were our first choice for this invitation, and they've all said yes. The only one who hasn't yet joined this afternoon is Professor Iqbal from Pakistan. But I'd like to welcome you and just run through the group of colleagues. We have Dr. Steve Khan, Professor Adeline Maganza, Dr. Shobha Chamania, Professor Amir Magazi, Professor Volker Sjoberg, and Dr. Tanvir Ahmed. And I'll just give you a few details about the individual people involved. Our two lead speakers who are going to give presentations are Dr. Steve Khan, who comes with the highest recommendation from the President of the American Burns Association. And Steve is the director of the Burns Center in Charleston in South Carolina, and he's going to give us one of the lead talks of the session. He's put a great deal of time in the last few years thinking about fluid resuscitation, and he's going to give us his distillation of the current state of the art on that. The next speaker is Professor Adeline Maganza, who's an outstanding individual who is the director of the Burns Center in Soweto in Johannesburg in South Africa, and hugely respected by colleagues all over the world. Similarly, Dr. Shobha Chamania, one of our panelists, is the director and really has built a fantastic burn center in Indore in India and has an outstanding reputation as an educationalist and a treater of burns patients. Professor Amir Magazi, like myself, is a plastic surgeon who also treats many burns patients, has a reputation as an outstanding reconstructive surgeon, and also a great teacher in burns, and I'm delighted to welcome Amir. Professor Volker Sjoberg, many of you will have heard of as a really renowned intensivist and specialist in fluid resuscitation in burn care. And he is also joining us as part of the panel. And finally, I'd like to welcome. Sorry, my links dropped. Tanvir Ahmed, who is Associate Professor in the National Burns Center in Bangladesh. And so welcome to all our panelists and speakers. And I'd like to introduce Steve Kahn, who's going to give one of the 2 lead talks on current key concepts in burn resuscitation. Thanks, Steve.
Thank you so much. I really appreciate the invitation from Mr. Watson and Khwaja. It's really an honor to be here and speak to you guys today, and also to be part of such a distinguished group of panelists. Anyway, so I am a surgeon with a background in general surgery, critical care, trauma, burns, and to some degree a lot of reconstructive plastics type work as well. My main areas of research are actually regarding firefighter safety, regenerative medicine, minimally invasive burn reconstruction, donor site sparing surgery, and my favorite topic, resuscitation, which we're here to talk to you about today. So I was tasked with a very challenging topic, and it was to basically answer this question: what are the brand new, most cutting edge treatments for burn resuscitation? What are the coolest things that people are doing? Well, the answer is there's really nothing new in burn resuscitation. And so now I'm faced with the challenge of talking to you guys for 15 minutes about absolutely nothing. I'll run out of jokes pretty quickly. I just ran out of jokes, actually. So although there's nothing new, our newer paradigms are actually old paradigms that we've gone back to. So I'm going to basically take you on a journey and go full circle to why we're currently using plasma, which I consider the most important therapy right now in my practice, and there's literature supporting that. So we're going to go over the history of burn resuscitation, where we started and where we are right now, talk about colloid, and then the newer concepts. This is really what's new, right? We're doing the same therapies, but our understanding of endotheliopathy and burn shock is really what's helped push this concept forward. And then now there's a lot of data emerging that you can reverse the endotheliopathy or the capillary leak with plasma. So when it comes to resuscitation, there are plenty of toys, bells and whistles, things that were standard of care previously. Maybe some people consider standard of care now, and some have come and gone. Crystalloid's obviously a mainstay, and then colloid. High-dose vitamin C is utilized in some centers, but it's kind of rapidly becoming out of fashion. Hypertonic fluids, there's some literature to support their use, but it's much older, and I don't know anyone that uses that right now. When it comes to monitoring your resuscitation, really the best thing in the world is urine output. I also use base deficit and lactate as adjuncts to that in my practice, but really nothing fancy. And then there are plenty of very expensive invasive devices that you can use for monitoring and goal-directed therapy. Now, there is some literature that shows that utilizing some of the goal-directed therapies results in better urine output, but really no mortality benefits. And these things range from the very invasive traditional pulmonary artery catheter. The only time I really don't very rarely use that in my practice. Maybe if a burn patient's having an active MI and is in profound cardiogenic shock. And that's really become their main problem. There's arterial line-based devices that measure cardiac index output by using pulse pressure variation, but there's limitations to them. Some patients need to be on the vent. There's also transpulmonary thermodilution, but none of these things result in less mortality. Echocardiography, there's very limited literature on there, but it's become a mainstay in my practice. I'll actually grab an ultrasound and do bedside transthoracic echocardiography. We also have a minimally invasive TEE device, which has been helpful as well. But the way I utilize this is generally in older patients with comorbidities, whereas 10 to 15 years ago when I was treating them, when they're oliguric, if you have a 70-year-old lady with a bad heart, we just go up and up on their fluids like a young person. Well, now I'll put a probe on them early and I'll follow their ejection fraction. I'll go to early inotropes and vasopressors instead of fluids. And sometimes I'll use some of those arterial line-based devices to titrate the inotropes, but usually I'll just use good old-fashioned blood pressure, heart rate, and urine output. So the current concepts, I'm going to take you on a trip sort of back to the future. This is a pretty iconic movie from the 1980s that I'm sure most of you have probably seen. Anyway, for those of you who haven't, a quick recap. Dr. Emmett Brown was standing on a toilet. He was a famous researcher. He fell and he hit his head on the toilet, and he developed this device called a flux capacitor, which allowed him to travel through time. So he surgically implanted it in a DeLorean. And he and his friend in the series of movies traveled back and forth in time. They ended up in 1955 and needed to get back to the future in 1985. So I'm going to take you on a similar journey in our DeLorean, all the way back to the Precambrian area. So if you think about this from an evolutionary perspective, right, we've had life on Earth for 2 billion years. And 540 million years ago, we started to see multicellular life. If you think about it, early multicellular organisms, their injuries were purely blunt and penetrating injury. Whereas humans, as multicellular organisms, have only been using fire for about 1 to 2 million years. So that's 0.3% of that 2 billion years to evolve and develop a protective strategy. And so I maintain that the response to burn injury is much more of a maladaptive response than that to hemorrhagic shock. You can lose 40% of your blood volume and not really get a huge capillary leak. I mean, some people will, depending on their genetics. But if you look at almost anyone who gets a 40% burn compared to that 40% blood loss, you're going to see this capillary leak. And I'll maintain to you that the holy grail of burn resuscitation that we need to do as a group is figure out a way to prevent or reverse that leak. And that's what I'm going to really talk to you about today. So now we're going to go back to 1942, the Coconut Grove nightclub fire in Boston. This is one of the first mass disasters in the United States where 400 people were admitted to 2 hospitals and only 171 survived. The burn sizes were not large compared to nowadays. But anyway, Doctors Cope and Moore really had developed the first burn size based formula. And not a lot is known about their initial research, but basically it was a mix of plasma and saline. Did not incorporate weight. Fast forward to 1952, and Evans, who developed the first burn center in the United States, came up with another formula where they mixed normal saline and plasma to a total of 2 cc's per kilo per percent TBSA. In similarity, they were working at Brooke Army Medical Center on a formula that involved crystalloid and colloid too. It was LR and plasma. And basically, these formulas that provided 2 cc's per kilo per percent TBSA were the standard of care, and they incorporated plasma for about 15 years. Then Parkland formula reared its head. And I'll say reared its ugly head because I'm not a believer in the Parkland formula. So we stopped using plasma. It was big during World War II, but in the late 50s, after some of this research came out, hepatitis really became a problem. So people started switching to albumin. Then a new theory that came out of Parkland in the 60s basically was that burn shock was primarily due to defunct sodium ATPase pumps, and extracellular sodium deficit is what led to basically pure crystalloid-based resuscitations. And they would replete albumin after the first 24 hours. The first 24 hours were basically just crystalloid. And there were fears about albumin extravasating into the soft tissue early on, which are not necessarily unwarranted. But a lot of that was data that came from in the 1970s from sheep and hasn't been proven as much in humans. But I think you'll see most people feel that it's safe to give albumin later on in the resuscitation. Whether to give it in the first 8 hours is a little more controversial, and there's people that feel strongly that you shouldn't, and there's some people that do. So now we're going to go all the way to 1968, and here's where the Parkland formula was published. It's a pure crystalloid-based formula, and they've gone up to 4 cc's per kilo per percent TBSA. All right, and this was initially done in dogs and then done in humans. They found that about 2/3 of the dogs needed 4 cc's per kilo, but dogs aren't people. So for the next 40 years, these crystalloid formulas became standard. And basically everyone in the United States started doing this way. Parkland formula is not that great. It's been shown to be woefully inaccurate in estimating fluid needs. In addition, people make mistakes when they try to do it, associated with hypoalbuminemia, and you get significant edema. And we really noticed that it led to a lot of fluid overload. So you get myocardial dysfunction, you get pulmonary impairment, more time on the vent, and then disastrous abdominal compartment syndromes. If you ever do a laparotomy on a burn patient, it just dramatically increases their mortality, and these folks don't do well. And increased risk of extremity compartment syndrome, so you all know that. So for 40 years, we've been doing this, and now we're going to fast forward to 2000, where Dr. Basil Pruitt coined the term fluid creep, which is also referred to as resuscitation morbidity, which was a term that Dr. Steve Wolf came up with. And basically what we found when someone did a summary of the literature was that when you looked at in the 70s, people were getting less than 4 cc's per kilo per percent TBSA, but in 2000, they were getting almost 8. So the fluid had doubled. And this caused a lot of us to ask the question, well, why? All right, and several reasons. People stopped using colloid, I think. Over-sedation and too much opiates, low blood pressure muddies the waters of resuscitation. Well, patients with comorbidities are now surviving, not doing well, and needing more fluid. lack of expertise, the surgeons getting away from the bedside, interns, shift work, and in the United States, obesity, a significant problem. So the ABA 10 years later put out a consensus saying, let's go back to 2 cc's per kilo. And so then we have the question is, how do we get there, right? So as in 2010, there was nothing really new in burn resuscitation, just like now. We started revisiting old adjuncts. So I'll just briefly touch on vitamin C because we don't do it. The theory is free oxygen radical scavenging, which we thought really was the hallmark of burn shock in the early to mid 2000s. It turns out it's more complex than that, and it's related to capillary breakdown, mitochondrial DNA, and DAMPs. Anyway, this was initially described in Japan. People started to try to do it in the United States and had a lot of bad outcomes. They weren't doing it the same way. One of my first projects as a fellow was actually getting us up and running at our burn center, and we were able to do it safely. But what we found out is that we gave these people an osmotic diuresis. It probably made them pee, and so they had good urine output, so we went down to the fluids. But we noticed everybody became very hemoconcentrated. So what did we do to treat that when they were oliguric? We gave them albumin and or plasma, all right? And we had great results. And now that I look back at it, I really think it was because we were giving them albumin and plasma and we were just making them pee, essentially diuresing them. So I'm going to take a second and talk about some of these colloids. Albumin, initially we thought these worked because of the colloid effect and free radical scavenging. Albumin, so I could talk for an hour about albumin, look at all the literature, but I'm going to talk for 30 seconds. So there's no real good literature that shows that it has a mortality benefit. The best level 1 evidence is from 1983, where they got less fluid but had higher mortality. There's tons of retrospective studies. You know, we talked about how it can leak out early on. Another thing too is that if a patient's woefully catabolic, like all burn patients are because of their hypermetabolic response, you'll just chew up the albumin you give them for energy. So it's an inexpensive food source, energy source. That being said, if they're woefully hypoalbuminemic, it does make sense to give it to them. So, and we do that from time to time. But I don't use it in my acute resuscitations. And there's currently an ongoing multi-center trial called the ABRUPT trial. So now we're going to rewind back to 1991, where in Pennsylvania, they were doing a plasma-based resuscitation therapy, and they found that patients got less fluid. This was replicated in 2005. In the 90s and 2000s, plasma started to become safe again. But despite their great results and what we knew about plasma previously, it never really became mainstream. Some additional data surfaced in burn patients about how doing a plasma exchange in patients who were failing burn resuscitation basically broke the refractory shock and made them better. But no level 1 evidence. This was retrospective. So going back to the 1940s and to where we are right now, we know that plasma works, but early we didn't know why it worked. We really thought that it was due to its free radical effect and its colloid effect. It turns out in 2013, if you look at more research done on burn shock in general, our understanding changed. In addition to just dilated capillary fenestrations, which is what I thought the fluid leak was from when I first started studying burns in the 2000s. Really a lot has to do with the glycocalyx breakdown. And here's a paper that talks about hemorrhagic shock. Now, if you give them plasma, it restores their glycocalyx, and rodents do better. They say this is rodents, this isn't people. So I'm going to continue to take you on the journey about where we are right now. So I assume pretty much everybody's familiar with the glycocalyx. It lines the capillaries. This is normal capillary on the left, the diseased capillary on the right. It's a glycoprotein polysaccharide matrix. It shields the endothelium from blood flow, prevents permeability, coagulation, improper leukocyte adhesion, and it's disrupted in almost any disease state or shock state. And that's why you get a capillary leak. Here's a good glycocalyx, and here's a bad glycocalyx with electron microscopy. Here's another picture. You can see this is what happens to a burn patient with all of that tissue edema, and you have that obliterated lining to the vascular lumen. So how do we move this forward from this experimental data in electron microscopy? Well, the first data started to come from trauma patients. We had some huge multi-center trials that basically compared hemorrhagic shock patients to getting blood alone versus or blood with a little bit of plasma versus a 1-to-1 ratio. Now, the patients that got more plasma had better mortality. Looking more closely, they studied some of these folks and they found that their sympathetic activation and the shock caused their endothelium to break down. And those markers of the endotheliopathy predict the mortality. So mostly syndecan-1 and P-selectins. And they also showed that beta blockers were protected, which we give burn patients. So now we've talked about rats and we've talked about trauma patients, and we're all interested in burns, right? So the first molecular data really that was interesting in burns came out of Washington Hospital Center from Dr. Shupp, who leads the research committee at the ABA. And he basically looked at rat lungs and also markers of endotheliopathy, and he looked at Evans blue dye permeation into the lungs and lung water, and also these molecular markers. And basically what he found is that if you took controls that were uninjured, burned rats that got LR only, 40% TBSA, LR plus albumin, LR plus plasma, the ones that got LR plus plasma had the least amount of molecular markers of endothelial breakdown. And if you look at pictures of the rat lungs and the data about blue dye extravasation correlates, you can see that the 40% LR plus FFP looks the most like the uninjured rat lung. Okay, so that's rats, right? Not humans. So how do we translate it over? There's not a lot written recently about it. We started doing this probably in about 2013 or 2014. In the United States, obesity is a real problem. So in addition to adjusting the Parkland formula, where I basically went down to 2 cc's or 3 cc's, I actually adjusted for their obesity using the same equation that they use to dose hydrophilic meds in obese dialysis patients. I maintain that you do not need to resuscitate all of the adipose tissue of an obese patient because it has a low vascular content. So this is a retrospective study where we used rescue FFP, and we basically found that they got a lot less fluid compared to historical controls. They had better urine, they had less urine output, which was good from our standpoint, because we went down to from 1.5 to 1, which is close to where we wanted to be. Where we're giving less fluid, should there be more AKI? Well, the answer is no. There was a significant reduction in that. There was a significant reduction in mortality and a trend for less pulmonary impairment in ventilator days and less trachs. And since then it's evolved, where I've started using even more plasma and less crystalloid. And now our last, I think, 10 resuscitations, 6 of them have gotten under 2 cc's per kilo per percent TBSA, which I'm very pleased about. And one of the things that I do differently now, here in 2021, as I've sort of gradually decreased the amount of fluid I'm giving my practice, is basically everybody gets 2 cc's per kilo unless you have all 3rd-degree burns and inhalation, then you get 3. If you show up with a 30 to 50% burn, you'll get 1 unit of plasma when you hit the door, unless it's basically like a 30% sunburn. If you're greater than 50% TBSA, I give you 2 units when you hit the door. And then the nurse has an algorithm where they titrate the lactated ringers at 2 cc's per kilo up and down by 10 to 20% per hour based on urine output, pretty standard. If they're oliguric for 2 hours, they call the attending or the consultant, and we make sure it's due to hypovolemia. And if it is, we give them 1 to 2 units of FFP depending on their burn size and their weight. And we adjust for obesity by giving less fluid and going 1/3 of the way the difference between their ideal and their actual. So that's my strategy. Early FFP is not as worrisome as early albumin. If you look at some of the molecular data about albumin shed, there's additional proteins in plasma that help decrease albumin shed early on. So, if you give albumin in the very beginning when someone's sick, it may extravasate. If you give plasma, it will just restore the glycocalyx and you will get less albumin leak. So this is the protocol basically that I'm happy to send anybody if they want. But more or less, if you do poorly, you get 2 units of FFP and you troubleshoot all the normal things. So we've kind of gone back and forth in our journey through time. We started in the 40s, giving crystalloids and plasma. We went away from plasma to just crystalloids. We found fluid creep. And now we're back to where we were, giving 2 cc's per kilo and plasma. So almost nothing has changed. We still give people salt water and chloride. I maintain that plasma is the most physiologic fluid and it restores the glycocalyx. Now there's some risks, transfusion reactions, viruses, immunosuppression, but it's probably better than albumin. And if you guys can figure out a way to give burn patients 1 unit early on, then it will likely have a large benefit and cut down on a lot of the other interventions you'll have to do. So the question for you guys is, can you utilize this new center based on cost, availability of product? Are you able to fractionate your own plasma? Is it safe? And can you get it from family members? So in summary, what's cutting edge in treating burn resuscitation? What's new? Absolutely nothing. We're doing the same thing that we did in 1942.
Thanks, Steve, for that fantastic run through. Really nice introduction, which has brought up many of the points that will no doubt come up shortly. Just Steve, is it possible you can unshare your screen, and then Adeline can. Adeline, do you want to share your screen? It's really interesting to see the history evolve over time of how we go back and forward with these things. Adeline, oh yeah, fantastic. So we're going to just hear Adeline's Maganza's talk next. We've heard our introduction of Professor Maganza, who's from South Africa and runs a very, very busy burns unit down there. So we're just going to get a slightly different perspective of different parts of the world, and then we'll open it to panel discussion about what other options there are in different resource settings. So Adeline, if you want to go to your slideshow, and then you're ready to go whenever you are. Thanks. Adeline, you're on mute, just in case you had started talking. You're on mute at the moment. Yeah, Adeline, you're still on mute. Adeline, if you want to, you're just on mute at the moment.
Had a problem to unmute myself.
Yes, I can hear you now. Yep, if you want to go to the start. Perfect, thank you.
Invitation and Stephen presentation. I think it was a very comprehensive presentation on fluid resuscitation. And what I'm going to do, I'll talk more on how, sorry, I need just to, I don't know if you can see me.
We can see your presentation very well, Adeline. Thank you.
Okay.
We see it perfectly. Thank you.
All right, thank you. So in terms of fluid resuscitation, and it's not moving.
Sometimes there's a little bit of a lag. If you just give it.
Okay. All right.
Great.
Okay. So we a patient and for hypovolemic shock. Failure due to inhalation injury. Patients have because of a septic shock. Now, we know, as it has been discussed, that fluid resuscitation is the cornerstone for effective burn survival. Actually, the aim is to restore the intravascular volume, we restore the organ perfusion, thus we prevent any organ dysfunction. And there's no doubt all studies have shown that it improves survival. And we understand, again, it was discussed, what is the balance between inadequate fluid and over-aggressive resuscitation. And we know that a delay in fluid resuscitation end up with organ dysfunction and mortality. On the other hand, if you are too aggressive with resuscitation, fluid creep the two. These are the things that we see a patient coming with facial burns and with too much fluid, you can end up sometimes with airway obstruction, and of course the infiltration of fluid into interstitial space. So what is the problem in low-income countries? That's where I wanted a delay in mortality. Found that most financial support issues because we're having large countries without infrastructures in many parts of Africa and some parts of um, some part of Asia, and there are some culture lay the treatment. Importantly, well equipped, lack of basic equipment, and training. That way, we have even interest in training of the patient. I mean, of the staff. In general, in low-income countries, particularly in Africa, in South Africa, I will tell you that went quite well with the EMSB courses and well basic or giving the fluid resuscitation, but you need to monitor the patient as well. So in terms of current fluid management, again, as it was discussed, most of them are based on some formulas. These are the two formulas used, and then the most 3 mils per. There's no doubt it's working. Just want to touch again, can we afford to give other fluid resuscitation in terms of lack of albumin? Those have been discussed. I'm not going into details. There are very few studies for the cost issue. Because most of the countries they struggle with basic stuff, so it's not really something that I would recommend. And it has been discussed as well, the high dose vitamin C. People are aware, we are reading, we heard about it. We use the advantage and disadvantage. But my readings is that in the last study that I've seen, actually it has shown that there's no difference in total fluid. There's no difference in ventilator days, and no difference into ventilated acquired pneumonia, and basically there's no difference in the mortality. So I think that so there's no robot fluid, and the plasma has been that it can reduce fluid requirement in acute phase, but the concern of transmission of a pathogen or transfusion, again, this is a tool which is quite difficult to implement in the low-income countries, because first of all, you have to transport this plasma, and many of this plasma you need for setting become a problem. So hypertonic saline, again, we know, we heard about this, but honestly, I didn't see much of the survival benefit by using resuscitation, I mean hypertonic saline as a. So all those tools, we can use them maybe on research. resources, but so been discussed and how you deal with a fluid resuscitation. As you know, Africa is a young continent, many young patient, pregnant, how you deal with fluid in a pregnant female. I've got interest in this topic. Patient with cardiac failure, how do you adjust your we do see with data support countries. The basic formula of Parkland or Brooks, I think works very well and prevent mortality in many, many patients. And the fluid associated morbidity remain a concern because of delay and sometimes over resuscitating or and others.
Grand, thanks, Adeline. I think your volumes are sort of coming and going quite a bit. I think we caught quite a bit of it, but it was a little bit patchy, so I may ask you to repeat some of it. Thank you very much for that presentation. That was quite comprehensive in terms of what different challenges you face. I'm going to ask you if you can stop sharing the slides, if that's all right, and then I'm going to ask the panelists if they're able to join back, if they're able to turn their cameras on, and then I think Mr. Watson is going to share his slides in a second once we're able to. Perfect, great. So thanks very much to our two presenters. Quite obviously common themes with the burn patients, but quite different volume and resources available, etc. So I was just going to really go around our illustrious guest speakers and just really start off with something a little bit more straightforward, then move into the areas which Adeline Maganza just touched upon at the end. And I might start at the most eastern side and work forward. So I'll start with Professor Ahmed and then come to Dr. Chimania, just to really find out how do you manage these sort of major burns, youngish patient, adults, 45% TBSA flame burn, no inhalation injury at this stage. We'll bring that in later on. And, how are you managing in your institution resuscitation? What are you giving? What formulas are you following? And then how do you manage sort of low and high resuscitation? Tanvir, can I come to you first, if that's okay?
Thank you. Actually, as all of you already know that in our country, we are dealing with a big number of burn patients in our emergency departments. So we are overburdened with the patients. So that is the big challenge in our setup actually. So, but whenever these sort of patients are coming, so we actually follow the Parkland's formula. And we heavily dependent upon the Hartmann solution. And but the problem is many of the times what happens, the patients coming from the peripheral part of the country are reaching late. That is a big challenge for us because already there is some under resuscitation and there is some problem with his renal functions. So actually when there is the oliguria is developed in such a big patient, big burn, then we actually try to cope with the increasing the fluid initially. That is, as usual, we used to increase the fluid for the 1/3 from the previous day with the crystals, and then and sometimes we use the mannitol. We use the mannitol, And if it fails, then we actually go for the loop diuretics like the Lasix. And we actually try to save the patient. And then actually we, at this moment, we have a nephrologist with us. And then we used to make consult with him and start to manage the patient. And we don't have any other facilities to actually deal with those patients. And we never use the bicarbonates or the vitamin C or any other things in our setting.
What affects, what sorts of delays are you looking at from the time of injury to the patients arriving in your unit, just on average?
Sorry, actually, there is an interruption into the voice, actually.
What sort of time delay are you looking at for time of injury to arriving at your unit?
Many times it reach even after 24 hours or even 48 hours.
Yeah, okay. And in terms of monitoring and things, are you using anything other than urine output?
Yeah,
basic obs?
Actually, in our hospital at this moment, in our new hospital, there is the Sheikh Hasina National Institute of Burn and Plastic Surgery, and we have 24 observation beds. At this moment, this is the winter time, so all of our beds are already full. So in 10 of our beds, we have all sorts of monitoring devices for the patients, but in rest of the 14 beds, we can do anything. So that is one thing. And number two, with the number of the caregivers. And number three, as our health system is completely government supported. So in many times, what happens, the supply of the fluids, even the fluids are not adequate. So Hartmann solution are not available there. In that case, we used to use the normal salines or the 5% DNS. In this way, we used to tackle the situation.
Sure. Yeah, quite a different experience from other parts of the world, I guess. Yeah, thanks. Thanks, Divya. I'm going to come to Dr. Chamani, if that's all right, to get perspective from India, which obviously will have a lot of similarities, but is a slightly different setup. Dr. Chamani, how are you managing these sort of major burn patients?
Yeah, I assume that fluid crystalloid has been given for some time, and in response, there is oliguria. The urine output is not coming. Maybe the patient has been there for a couple of hours. I guess 8 to 12 hours, and the response is poor, less than 0.5 ml per kg per hour. So I would like to review the diagnosis, whether the assessment of the burn percentage is correct or the burn depth is correct, because it may be possible that the burn depth is more, and so he needs more fluids, and the extent of burns also may be more. The weight may not be calculated, and that can also be reviewed. So first is review the assessment, and then correct the crystalloid provision based on the reviewed assessment. And if that doesn't give any good urine output in next 2 hours, then we usually use colloid challenge at this point. And fortunately for us, we have seen very good response in terms of urine output improving after colloid challenge. And we do not go by any formula of colloid like 0.3 or 0.5 ml per kg per percent for next 24 hours, but it is because of the cost issues, the patients cannot afford so much of colloid. And so the moment urine output improves, we switch over again to crystalloids and tide over the patient with good urine output.
Thanks, Shoba. I think you answered the question I was just about to ask, that the patients are they paying for all of the care or parts of it? How does that side of things work for the resuscitation phase?
Ours is a private hospital, so they pay for everything.
Yeah.
Everything in the pocket. Most of the patients are not insured, and so it's very difficult to have poor patients come in and pay from their pocket.
And I suppose to lead on from that, before I come to Dr. Magazi, is how do you start to introduce things like the vasopressors and inotropes? At what stage would you start to consider those?
Yep, well, for me, we don't consider 0.5 is already oliguria. We consider oliguria below 0.3. So between 0.3 and 0.5 is just fine for us. So we don't do anything more. But if we are below 0.3, which is our critical level, we start by augmenting the crystalloids. Then we will try the renal dose of inotropes. And if all this fail, we will go to the colloid challenge.
Great, thanks. So some quite different experiences. Adeline, if you're still there, I might get you to just repeat a little bit of what you're doing in your unit, because your voice was coming and going a little bit in the presentation. We'll see if it's a little bit better now. So just, Adeline, are you there? Oh, you're on mute then.
Oh.
Hello. Oh yes, go on.
Yeah, I was saying that I'm not sure what's going on with our internet provider now, but I think I agree with the previous speaker. We will accept 0.5 mils per kilo, and then we will
I think we're probably losing you again, Adeline. It might be a little bit too patchy, your internet. We might try again in a second or two, if that's okay.
Change, yeah. I'm going to change it. Okay.
Yeah. Well, perfect. Yeah, that might be something worth trying to do. Great, thanks. So I think that was a reasonably sort of the more straightforward end of things. But then starting to add in things like inhalation injury and the things that Dr. Khan in particular touched upon, things like fluid creep and all the inhalation injury problems. How are people managing those in the limited resources or the different situations you have? Has anybody got any particular things they find work well or particular challenges for them? Either Tanvir, Amir or Shoba. And then after we answer this question, I might come to Professor Sherberg and Dr. Khan again, just to sort of give their comments. For inhalation injury, how are you guys managing that? Anybody want to go? Or Tanvir, do you want to, Tanvir or Shoba?
Yeah, thank you. Actually, we are getting some inhalation injuries here due from the accidents, and in the fluid resuscitation, it creates some problems. So we are trying to fix the problem with strict monitoring and the strict calculation and then and the calculation and monitoring of the patient. But in addition to the those management, actually now we have some if there is if required, then not in every patient, but in some cases we are now able to early intubation of the patient if there is a serious problem with this his maintenance of his airway. And number two, in some cases, we are able to use the hypertonic salines, but it depends upon the supply of the supply from the government fund. Otherwise, it is really, really very difficult for us to manage the severely burned, the inhalation injuries.
Right, thanks. And Dr. Toumani, how are you finding you're managing the major burn with the inhalation injury from the fluid resus point of view and the supportive therapies?
We begin with the diagnosis of suspicion of inhalation injury. We do not really do bronchoscopy on admission and confirm the diagnosis. And so there's only a historical and clinical suspicion that this patient may have inhalation injury. Begin with crystalloid resuscitation. And if we don't see adequate urine output, then the suspicion is somewhat towards the inhalation injury complicating the issue. And we use hypertonic solution for the initial resuscitation period in these patients. And it's ringalactate with soda bicarb, 50 cc in it, till the urine output becomes 0.5 ml per kg per hour. And then we move on to ringalactate again. And if the response is good, then we continue with crystalloids. If not, then we use sometimes colloids. In this, though, with the restraint, we usually wish to continue only with crystalloid in inhalation injuries. Intubation and ventilation is possible in our situation, but we try and avoid that because we don't have a burn ICU and we manage our own patients. So in our situation, the parenchymal lesions are very few, and very few patients have those lesions. Most patients have just the upper airway injuries, and we are able to sort of manage the airway without doing an intubation by very good nursing care and nebulization and observation, keen observation. Only patients who have severe inhalation injury involving the arteriovenous shunting, those are the patients who finally need ventilation, and probably after surgery they're just put on ventilator for a long time.
Thanks, Shobha. Thanks. There's some good questions coming through. I'll go through those in a minute. I'll ask the panelists one or two questions about delayed presentations with Parklands and one or two other questions. Just to come back to Dr. Meghazi before I open up the floor a little bit more. Just tell us, Dr. Meghazi, again, from the initial resuscitation side of things, how's it working in your unit from the point of view of the delayed presentations and the cost to the patient and the facilities that you have available? Do you have the sort of full range of things, or do you have certain limitations?
Yeah, we also have the same limitations, and I think also I personally didn't see much cases of true inhalational injury. Most of our cases that come to us are usually upper respiratory burn injuries, so we didn't see actual pulmonary injury with these complications. But in general, if we suspect these cases, we used to shift to the central venous pressure just to adjust the fluids, because we are very afraid of the over resuscitation than under resuscitation. So our policy in general is to keep the patient in the dry side rather than the wet side of the equation. I think also now, as we published about the oral resuscitation, we are going more with oral resuscitation, even up to 60% as a base to start with. This also depends upon the patient condition, the delay. Even with the delay, more than 6 hours, we start with what we call combined resuscitation, that oral and IV.
And that's great. I'm glad you brought that up about the oral resuscitation, because that must be a common theme that you're all doing. What are you giving for the oral resuscitation? How are you managing that side of things?
In general, we give the ORS as we published with supplement salt. This is our general is 5 grams of salt for every 1 liter of ORS. In addition to that, we let the patient drinks whatever he or she wants as natural juices. What is available in the market, like orange juice, strawberry juice, sugar cane, which is very common in Egypt, and it is very well diuretic also because it increases the diuresis. So the basic is the ORS with the salt and liberal of whatever the patient wants, except the sodas and the alcoholics, of course.
Great, thanks for that, Amir. Professor Sherberg, you've unmuted yourself, but before you say, I'm going to ask you a question, if that's all right, because it's one about ISBI guidelines, saying that the recommendation is 0.3 mils per kilo per hour of urine output. I think the question is, do people feel this is adequate or not? Professor Sherberg, have you got any thoughts on that?
Yeah, well, I would say that there is the study by Dr. Greenhalgh who looked at the procedures around the world, and it very much supports a Parkland-like formula. And I would say that most would advocate a little bit less due to the risk of over-resuscitation. And what I hear from the speakers today and the participants in the panel, I'm very impressed by the homogeneous way of looking at the resuscitation procedure. And I would just like to underline that if you're not very well situated and you have a special interest in early colloids or plasma, a very good alternative, of course, is the crystalloids. But one has to be aware of the risk of over-resuscitation, especially when the burn size gets below above 50 or 60%, or the fluid volume that you actually need to give in order to produce the 0.5 mils per kilo in urine output. If you very much need to go up above 15 liters or so per 24 hours, or more than 300 mils per kilo and 24 hours, then you're at high risk of developing abdominal compartment syndromes. But if you, in that situation, you can always, of course, use a colloid rescue procedure by adding colloids, plasma, albumin, and so forth. So I think summarizing a little bit what people are saying, I'm very content to hear that people seem to follow the guidelines of the different burn associations.
Thanks, Volker. That's great. And actually, on that point, another nice thing raised about abdominal compartment syndrome. Any of the colleagues seeing abdominal compartment syndrome in the practice? Do you monitor for it, or is that something that comes up because of fluid over resuscitation? Anybody wants to take that one?
I would say that in our practice, we've virtually eliminated it. In the past 7 years, I've had to only do one laparotomy on a patient, and they had the worst inhalation injury that I've ever seen. They were actually a relatively small burn, only 15% TBSA. But since we've switched away from that Parkland formula, intentionally giving less fluid, really it's been virtually eliminated in my practice. And I've noted a lot of my colleagues have seen the same things. By reversing that capillary leak early, you're preventing yourself from getting in that scenario. You know, there's that old adage, fluid begets more fluid. So you really want to try to do what you can to restore the oncotic gradient or reverse that leak before you get into trouble and you have that snowball effect.
Are you actively monitoring for abdominal compartment pressures, or is that on clinical grounds once they start to develop a problem?
Not on all patients. So just to kind of bring back full circle to where we started with that first patient, you know, I think the key is having an algorithm to troubleshoot with difficult resuscitation. And people have really touched on that. And that's part of my algorithm, right? So Dr. Chimana touched on her algorithm, which one of the first things that we teach the residents or the registrars to do is to go take a look at the burn size, make sure it hasn't converted. You know, with your patient who you showed, I noted they had circumferential extremity burns and they're 45% injury. So they're a few hours into it and they're oliguric. They probably need escharotomies. You know, and we would do that prophylactically with an injury pattern like that, you know, at 2 p.m. as opposed to at 3 a.m. So, you know, how do you approach your difficult resuscitation? Number one, look at the Foley catheter, right? Is it functioning properly? You know, you don't want to give a bunch of fluids for that. Is it because it's cardiogenic shock and not fluid overload? Is it an unrecognized inhalation? Is it cyanide toxicity or carbon monoxide toxicity? You know, and there's a whole host of things you can go down. So I'd encourage everyone to develop one in your center and get buy-in from your team and do it in a thoughtful fashion and have everybody doing it the same way. But just like Dr. Magazi, I like the idea of accepting less urine, which is not universally accepted in the United States. But just because Mr. Watson might do fine at 0.49 cc's per kilo if he's being resuscitated, but maybe I need 0.51, right? And so if he's making 29 and he's doing fine, otherwise he's not mounting a base deficit, his lactate's not creeping up, I would just let him go and accept the oliguria as well.
Yeah, there's a really nice phrase from, I can't remember who I heard it from, that you're not trying to get normal physiology, you're just trying to get some renal function that's going to keep you alive till you can treat the rest of the patient. So sometimes the juniors are often trying to get back to normal, which is difficult in a major burn injury.
And the other thing too is not treating the urine output, right? The urine output is a marker of your volume status. So I want to treat the volume status. If I think they're hypovolemic, I want to give them more volume. If I think they're overloaded, then I want to take the volume off.
I don't know if other colleagues want to come in here, but I guess urine output probably is the main method of monitoring it, because other ways of doing that are probably not available. Would that be a fair point? Yep, there's a few nods going on, so I'm taking that as a yes, really. There's a question. Oh, sorry, go on.
Sorry, yes.
Oh, yeah, go on, please.
Yeah, I agree with you. We don't have those invasive monitoring devices. The only monitoring we do is urine output, and not too many lab investigations also.
Thanks. Dr. Magazi, how are you guys doing? Are you essentially the same thing?
We have some facility that we can do sometimes specific gravity of urine and osmolarity of urine. So this is more sensitive and more specific to the status of the patient rather than the output. So if the specific gravity and osmolarity is good even at 0.3, we would continue to that. But actually, as we don't have this as a routine for financial reasons, when the patient drops up to 0.3, we start doing this, have the specific gravity and osmolarity to see if this is a normal process, because we are giving, from our point of view, appropriate and not over resuscitating, or it is a problem of oliguria due to concentrated urine, due to lack of circulatory volume.
Great. Thanks.
Can I come in and maybe?
Yeah, we can hear you much clearer now, Adlin. Yeah.
Yes, I'm very sorry. I had a problem with one provider, so I've changed. I was just saying that the 0.5 mils per kilo of this urine output, we do accept that as a urine output for major burns. And if it goes below that, and then we will make sure that this patient doesn't have a myoglobinuria, because that's how they started to go into renal failure. And we'll push fluid. Then if it doesn't work, then we'll go to other means. Provided that the blood pressure is fine, then we introduce other things like Lasix, even mannitol, if we suspect a myoglobinuria. Now, when it comes to monitoring, we're quite very aggressive in terms of monitoring this patient. And we, beside the urine output and vital signs, we do quite a routine blood cases. And in patient in ICU like this one, we'll do even every 2 hours, sometimes every hour if necessary. And we believe that if you follow the lactate and the base excess of this patient, actually it's even more accurate than the urine output to give you a sense of how your resuscitation is good or not. That's what we'll do. Thank you.
Thanks. Thanks for that, Adlin. Yeah, that's much clearer now. We should make you do your whole talk again, but we'll we won't make you do that just yet. There's a couple of questions.
A point?
Yes, please, Volker. Yeah.
I think there is one piece of knowledge that I think everybody would need to appreciate a bit, and that is, if you look upon the Parkland formula or the early crystalloid resuscitation with the mils per kilo and giving half of the volume the first 8 hours, you should be aware of the fact that your patients are actually hypovolemic all the way until 14 hours. And that needs to be appreciated, especially in elderly, because that is if you have a very young population, which I anticipate in the developing countries mostly, then you will have a very good ability for the person for the kidney to recover that challenge, which is important. And secondly, that also is, if you have a delayed exposure of the coming out of the patient, you will also have the fluid volume accumulate and become edematous after 24 hours, and especially after 12 to 14 hours. So these are important. And further, a physiologic point is that when you resuscitate people with crystalloids, you will get a falsely too high glomerular filtration rate due to the fact that the crystalloids have a tendency to increase the filtration rate beyond what is physiological for the human. And this is also a possibility of a false too high urine output. So I think in youngers in which you actually provide large volumes, you may anticipate that the need for urine output might be 0.3 or 0.5 will be quite sufficient. And I would advocate that, especially in the resource limited situation.
Thanks, Volker. That's really a really helpful way of looking at that side of things. I'm going to ask you a couple of questions in a minute, or a couple of opinions about pregnancy and obese and different states of nutrition. But before we move on to that bit, there's a few questions in the chat about delayed presentation and what to do with the resuscitation in terms of if you're 10, 12 hours later, what do you do with your Parkland's formula? So Tanvira, may come to you first for that, if that's okay. And then there's also a question on a similar theme. What if your patient comes at 24 hours? Do you use a formula, or how are you starting your fluid? So I'll ask colleagues what they do with that in the delayed situation. Tanvir, how do you manage that?
Thank you. Actually, frankly, we actually follow the Parklands. We actually, because it is very easy to calculate for our doctors working there, and they actually start the fluid according to that formula. But immediately after receiving the patient, we actually go for the catheterization, and we try to secure the channel with actually straight away we try to go for the central venous lines, because our doctors are capable to do this, except the pediatric patients, we need the anesthetists. So then we go for the output. Then we actually into the upper side, that is 1 to 1.5.
So do you start the resuscitation at what it would have been for that hour, or do you give them extra from the previous hours that they've not had?
Yeah, actually, we actually give the fluid challenge. And actually, in this way, we actually go with the Hartmann's solution. But in some cases, as we have our blood bank, and we try to give the fresh frozen plasma. And in some cases, I previously told, then if it was not managed with the fluid challenge, then we used to go for the mannitols or the Lasix, then return back, because the albumins are not widely available or very expensive or difficult to manage. So actually we heavily dependent upon the fluids, then some mannitols or something like that.
Sure. Yeah, no, thank you for that. And Dr. Chamani, do you get any patients at more than 24 hours? Is that a thing you experience?
Plenty.
Yep. Okay, so how do you manage those fluid ones?
But then it is true that these patients have been in some facility where the IV fluids were not managed according to a protocol. So they're not completely dry. And if it is a pediatric patient and breastfed, then probably the baby was breastfed during the 24-hour period that patient did not come. So some intake has been there, and you pass the catheter, find what is the urine output like. And urinary spot sodium can tell us about the situation of hypovolemia without much intervention, because if that is less than 5, then it is indicative of hypovolemia. This patient is dry and needs volume replacement, whether you use a hypertonic saline in the beginning, because now it is past 24 hours. So the capillary leak stage, which was more prominent in the first 8 hours, is over. So we need to give fluid, reducing the amount of fluid that they have already received, and remaining amount can be started as hypertonic saline, and then keep a watch on the urine output, because that is most important. If the urine output does not pick up, is less than 0.5 mils per kg per hour for next 5 to 6 hours, then renal functions, which should be done on admission in such kind of patients, should be reviewed, because here is the risk to kidney injury. And this patient's creatinine can be checked again, and electrolytes should be seen. They may have severe electrolyte disturbances also, which need correction, because in pediatric patients, we see a lot of seizures in such patients because
Yep.
of hyponatremia.
Well-
And though that hyponatremia also should be very slowly corrected, because if you rapidly correct it, then it also leads to problems in the pontine region.
Thanks, Job. I was going to ask, as you mentioned about renal problems, what options do you have available for renal replacement therapy for if any patients start to have renal injury and renal failure?
So we do have nephrologists, we have dialysis available. We don't have CRRT, but we have SLED. And pediatric patients is a challenge. We've rarely had pediatric patients going for dialysis, but adults, very often they are offered. The nephrologist comes into picture the moment oliguria persists, and the volume replacement has not helped the patient. Creatinine is rising, and he takes over, and then he decides when he wants to do the dialysis.
Sure.
In fact, the fluid modulation is also done by him.
Great, thanks for that. And Dr. Magazi, anything to add to anything different you're doing with delayed presentations in Egypt?
Yeah, not in Egypt. I'm talking about where I work, of course. Generally, as I've said, we now are depending more on the oral, but when the patient is coming late like that, we start what we call the combined. We start the oral and the intravenous. And here the intravenous, I usually prefer to use the Dextran 70. Dextran 70 is very good as it's a plasma volume expander. And these patients usually suffer from severe home concentration with the problem of coagulation and thrombosis. So the Dextran 70 has both advantages of expanding the volume and preventing the thrombosis problems in these patients. And then we start also, if needed, with Ringer solution IV. We usually expect the patient to be between brackets normalized after 3 to 4 hours. So we don't do any aggressive interventions except after 3 or 4 hours when the patient is not responding. Either the urine output is not 0.3 to 0.5. The general condition is not better from the confusion or these things. We start to call the ICU, and we start to move the patient to the ICU unit, and we don't manage in our unit, as we don't have intensive care unit where I work.
Thanks, Dr. Magazi. That's interesting. Dextran's something that used to be around a while back, but it seems to have fallen out again. Professor Magazi, I was going to ask you if you had anything to add to that. And if you do, then obviously please do so. And then also I was going to ask you a little bit about your pregnant patient, because there's a couple of questions about that, and sort of fits in the similar areas about patients with large body habitus and large breasts or BMI. How are you managing those?
Yes, no, thank you very much. The question was patient present after 24 hours.
Yeah, 12, 24 hours, that sort of time.
Yes, yeah. So actually, for those patients, we forget about the Parkland formula. We forget about any formula. So we'll assess the patient, and then if patient is, let's say, in shock, and we'll treat this patient as a trauma patient, meaning that we'll go with boluses of crystalloid fluid, and then we watch again how he's going to respond, looking at the vital signs, urine output, and blood gas, and so on. Now, if a patient is just dehydrated, of course, we'll give him a bolus, and then we'll follow up. And in those patients, actually, after 24 hours, I agree that we'll start with some enteral feed immediately as well, as part of resuscitation, but it's more IV fluid. Now, in terms of renal failure, there was a question that you asked for patient presenting with renal failure. Actually, we doing a total burns care, and for those particular patients, what we found is you need to start the dialysis a little bit earlier, because if you wait too long and patient become hemodynamically unstable, actually mortality is very high. It can go up to 80%. And the best way of dialyzing this patient, we found it is a continuous dialysis. Intermittent dialysis is not very good in the burns patient because they go quickly into instability. So that's what I wanted to add. Thank you.
Thanks, Professor Muganza. And also, if I can just ask you to comment a little bit, because the volume in your talk was a little bit patchy. You mentioned about pregnant patients with major burns, that side of things. If you just remind us any particular differences that how you manage that difficult group.
Oh, yes. I think that is a challenging condition. But first of all, if a patient is less than 6 months pregnant, most of the time you treat them like any other patient. But the problem arises when it's, let's say, 30, 32 weeks pregnancy. Then you know that the size of the abdomen is bigger, and then you've got a fetus. And so there is a formula where you can actually add some percentage of burns to the abdomen, and then you can increase as well some fluid. I think it was published somewhere. I can't remember again the journal, but that's what we follow actually.
Great, thanks. And just last question, Prof. Muganza, is what do you do with, how do you in your total body surface area calculation deal with large breasts and sort of obese patients? Do you sort of include that in your TBSA, or do you not really, the way Dr. Khan was saying that you're not really trying to resuscitate the fat? How do you manage that?
I totally agree with that. We don't really go because of, we look at the ideal weight for the patient. We look at the age and the ideal weight of the patient, then we decide on that. We don't go, someone has got, let's say, 150 kg, and we don't push fluid for such patient.
Thanks for that. There's a few questions coming through in the Q&A about children and electrical burns. So in 2 moments, I'm going to pass over to Stuart Watson, who's going to bring up that scenario. Before I do that, the last part in this section, I was going to ask my colleague, Jorge Leon Villapolas. He has a point to raise and probably a question for some of the panelists as well, relating to the fluid resuscitation and hypothermia and certain aspects. Jorge?
Yes, thank you very much. First of all, congratulating all of the colleagues for their excellent contributions, basically, and I think that all of us are learning a great degree. I think that I just wanted to raise a point that hopefully will be shared by my colleagues in here, which is not looking at fluid resuscitation as just a single strategy that is going to get you out of trouble in the early period of admission of a burn patient. Characteristically, what we want to do is just restore the markers of hypoperfusion in this patient and get Basileus back to a degree of not normal, but near normal physiology. And we cannot do that only by just simply addressing the fluids, but also taking into consideration that there are other parameters like the control of temperature, that is specifically hypothermia, and the control of acidosis that play a phenomenal role in how we manage the resuscitation of these patients. At this stage, I think that I would like to ask my colleagues if they feel that the management, or to which degree they feel that the management of hypothermia influences in their resuscitation regime, and how do they control basically the acidosis and take the patient just back to a degree of normal perfusion. Thanks.
Thanks, Jorge, thanks. Just seeing if there are any comments from anybody at that stage. Yes, please, Volker, yes.
First of all, I think depending a little bit on your equipment, but if you use convective heating devices, you're usually able to, within 2 hours, to correct most temperature decreases that you see. Depending a little bit on the facilities that you have, but our experience is that it can be done when you have the right equipment. The issue, though, is when you don't have that, then you need to have other ways of doing it. And when you have other ways of doing it, that will affect your resuscitation. And again, for example, if you're very hypothermic, you will have a hypothermically induced hyperdiuresis, which might fool you in your interpretation of the patient. So I would caution to not try to do your best to get the temperature into the normal range again.
Thanks, Folky, for that. I'm going to, oh, sorry, Shobha, yes, please.
Yeah, so fortunately, we are not such a cold country, and our environmental temperatures are even today, it's like 25 degrees during the day. So hypothermia and the environmental temperature control is not very difficult in our situation. We use the convection modalities during winter season, which is like 3 months at the maximum. And rest of the time, the temperatures are not very low. I mean, I understand that it should be somewhere around 29, 30. So if the patient has cold extremities, we definitely use heaters. But otherwise, we are blessed with a warm climate.
Yeah, that's an important difference, isn't it? And we're obviously not jealous at all of the warmth and heat you get. Thanks for that, Shobha.
Yeah, I also go with Shobha that we don't have that problem of hypothermia except in children. Actually, this is the only problem because they usually wet themselves and we have their surface usually hypothermic. So we keep them covered always, and we try to get heaters in their rooms. But for adults, we don't have much problem with hypothermia.
Thanks for that. Steve, you've got a hand raised. Were you going to?
Yes, you know,
Yeah,
I would say when it comes to this too, don't forget the simple things. So when I went and rebuilt the first burn center that I ran in Alabama, I noticed that patients were getting room temperature crystalloid, or just simple things like warming up the crystalloid in this scenario is sometimes overlooked. You know, warming them with plastic blankets, Mylar reflective survival blankets. You know, they're really inexpensive modalities that you can use, even if you don't have convective heaters, diffusive heaters. You know, and these technologies range all the way up to, we have these really nice vent circuit warmers that give you basically a 40 degree up to 42 degree blasts into your tracheobronchial tree. That really, really works. And there's fancy warming catheters out there, you know, but you don't have to spend all this money or have these devices. Just, you know, go back to basics. Just make sure everybody's doing it the same way. You know, you can put the fluids near a heat source and just make sure you're warming them up. Not too hot, obviously. You don't want to give somebody 140 degree fluids, but there's a lot of little things you can do.
Great, Steve. Thanks for that. Great, thanks. I think because there's a number of questions coming about pediatrics, Stuart, it may be worth us moving to that next scenario, if that's okay.
Thanks very much, Nadine. Thanks for sharing. I've just got so many things I want to ask and talk about as I take over as chair. I'd just like to follow up, since Amir mentioned children. We've been talking about urine output, and I get a strong consensus that we're happy with urine outputs in adults of 0.3 to 0.5 mils per kilogram. Amir, do you have any different view about what urine output you would go for in children? What do we think about that? Amir Moghazi, Professor, first of all.
Yes, as for children are different, so we usually prefer to have their urine output more than 0.5. We are talking about adults about 0.3 to 0.5, but urine output for children would be much more. It's about 0.5 to 0.8 due to their different fluid composition. Also, the oral resuscitation and oral supplements are much better tolerated with pediatric patients. So we rarely now give IV fluids to pediatric population, less than 30% total body area. The only problem we have with the pediatric patient is how to make them away from the hypothermia, because they are always wet with themselves. So this is our only concern, and most of our population still don't accept the relatively warm rooms of the children. They think that the warmth of the room will increase the bacterial invasion and it will be dangerous for them. So it's a cultural belief that the problem with the hypothermia in children mainly with the families rather than with the medical staff.
Thanks very much, Amir. Thank you. At this point, one thing, just in case we don't revisit this, we may not have time to, just to emphasize something that Amir has emphasized already and Shoba emphasized to me before the start of this, for the audience from relatively lower resource countries who are seeing a lot of patients with delayed presentations. Do listen to what Amir has been saying about oral resuscitation for these patients who might be presented to you delayed from other centers, and work on education of the other referral centers about oral resuscitation prior to coming to you, and the value of that in the patients who may come to you delayed from other centers. Oral resuscitation is a huge potential area of advantage in limited resource settings. Now I want to move on and pick up on something that Tanvir said before about using fresh frozen plasma. And this has been absolutely fascinating to me that we had Steve starting off from high resource setting, all the chances in the world, and he has presented a relatively low volume crystalloid fluid regime with deliberate use of fresh frozen plasma. And Tanvir, working in a different setting altogether, has described a similar regime where they would rescue the patients with fresh frozen plasma. Steve obviously uses FFP purposefully. Steve, could you just enlarge a bit on your view about the value of using FFP and the potential accessibility of it in certain parts of the world in resuscitation?
Yeah, absolutely. As you all know, it's really dependent. There's more of a shortage in lower income countries. I reviewed the World Health Organization data. I believe there's over 100 countries that have access to FFP, whether they're fractionating on their own or whether they're having it imported. You know, that being said, as we've touched upon, some of the limitations are the expense and also the quality of it. You know, you don't want to give a 14-year-old hepatitis C or something along those lines. But you know, then you could ask yourself the question: well, is that better than dying from burn shock? You know, and that's an individual value and judgment. You know, and I don't know a lot about the healthcare systems of the individual countries, but if it's something that you can invest a little bit of time and resources in to where you can do this, even though the data, there's not a lot of the level 1 randomized data. Everyone who's doing this in the United States now, probably at least a dozen burn centers are using this sort of this form or fashion deliberately, and everybody's universally seeing those same results. You know, and when you look at the molecular data, experimental data, it's much stronger than we've seen in previous iterations of looking at different adjuncts to resuscitation in the 60s and 70s. You know, it's not a magic bullet, it's just an adjunct. And as time goes on, and I use it more and more, I've just been more and more impressed with its results on the patients. Same thing with delayed resuscitation. I would give them FFP early. I'll find that 80%ers, we resuscitated a 60-year-old with 83% full thickness burns, and he essentially got an FFP infusion his whole time. And now he can ride a lawnmower, carry a baby, and he can hold a can of beer in his hand that we didn't have to amputate fingers on.
Thanks, Steve. Adeline, can I please bring you in now? Because it's very important that we take recognition of the challenges that people in Africa face. And obviously, in many countries in Africa, viral transmission from transfusion and blood products is more of an issue. What's your position with FFP for rescue colloid or colloid use in burn resuscitation? Is that something that is realistic in many African countries? And if it isn't, what are the alternatives? Adeline, can you hear me? Professor Muganza?
Yes, I can hear you well. Yes, thank you very much. Unfortunately, my talk was not clear because of connections with the internet. But what I said is I look at data with FFP in fluid resuscitation for burns. Actually, they are very weak data. And in low-income countries, I say that I don't advise to use the FFPs, especially in acute phase. First of all, most of the FFP, I don't know in other countries how it is commercialized, but here in South Africa, it's first of all very cold. It's a high cold. And we just talk about patients that we must avoid hypothermia, because we've seen that hypothermia actually has a poor outcome in a patient. So we really don't use FFP as part of resuscitation or any adjuvant to crystalloid resuscitation. However, we do use FFPs only in patient who has some coagulopathy. Some patients have a raised INR, and you have to do maybe debridement and so on. That's something else. It's due most of the time to sepsis. So as it has been said again, data are not really convincing, and for low-income countries, I think they must do the basics, which has shown clearly that it can improve survival. Is a fluid resuscitation with a crystalloid. Thank you.
So, Adeline, can I ask you, we heard from Amir earlier that if he's struggling with a fluid resuscitation to get a good response, he would use crystalloid, obviously initially, and then he might use a renal dose of an inotrope and then use colloid. If you're really struggling with your crystalloid resuscitation, what would your next step be? What would you recommend for colleagues working in the African setting? Amir Magazi has obviously recommended possibly the sequence of a renal dose, inotrope, and then colloid. What's your sort of view on that pathway, that algorithm that Amir Magazi put forward?
Okay, thank you very much. In majority of these patients, in the first 24 hours, we always recommend crystalloid. But I understand the point. After 24 hours, you may find that the patient, despite the crystalloid infusion, they don't do well. And I've seen patients where, unfortunately, you have to start with some inotropes. Once you're sure that you've done a good fluid resuscitation, and those patients, it has been described that some of the patients with major burns, they can develop some kind of cardiac apoptosis, and that can lead to some form of cardiac failure. And then you may start with some inotropes. But in general, even those patients, you'll find that the prognosis is not good. And few studies I've seen shown that if you start early, those patients, or they needed inotropes, the outcome is not good.
Thanks a lot, Adil. Thank you. Can I ask Shoba first and then Tanvir, what's your perspective on the value of using inotropes in your setting as an adjunct to the really struggling resuscitation? Shoba, please.
Thank you, Stuart. What Amar had said that renal dose of inotropes would be given, I think there's enough evidence to say that this is not effective. The inotrope that was used was dopamine in renal doses, and it has been proved that it is not effective. So what we do is we measure the blood pressure, and if the blood pressure is maintained enough to assure the kidney perfusion is maintained and the GFR would be maintained, then we do not start inotropes. But if the blood pressure is low, then just to maintain the kidney perfusion, the inotropes are started. And in our setup, we use noradrenaline. We have not used vasopressin as till now. And
thanks very much, Shoba. I suppose that mirrors our practice at home here, actually. We use noradrenaline to support the circulation and the failing resuscitation. Tanvir, do you have anything to add from that in your perspective in Bangladesh, treating large numbers of patients? Is there some role in that perspective with your huge patient population for use of inotropes, or is it not something that you can really get into?
Thank you. Actually, we are heavily dependent upon the crystalloids. That's frankly speaking, and actually in some cases, because due to the load, we can't actually monitor the patient meticulously. So actually, if required, then in HDU patients, actually we have 60-bedded HDU. So in H2 patients, we actually focus on the inotropes. In other cases, we can't. But firstly, we are depending upon the crystallars. Then if recurs, then we go for the colloids after the 24 hours to maintain the perfect things.
Thanks a lot, Tanvir. Folke from Sweden, as an intensivist of international.
Well, yeah, what I would say is that vasopressors should be used with extreme caution and noradrenaline not at all. If you use the Parkland formula, you have a hypovolemic situation for the first 12 hours. If you add on an inotrope on that, you will get increased number of renal failures. We're coming out with a paper showing this effect in Sweden, as there has been a popularity of, in different ICU settings, use inotropes without certifying that the organ perfusion is sufficient. And especially with the Parkland formula, which is well known to produce a hypovolemic period, there is very large dangers in using inotropes. I would strongly advise against it.
The only thing, though, my understanding from what Shoba said, Folke, was this was later in the patient who is struggling, maybe 24 hours or something like that. Is there an indication then? Do you feel that that's more realistic at that stage? Not so much early in resuscitation, but later?
Later, it becomes, especially from the physiological point, it becomes more reasonable. But there is always the issue of whether you are in a hypo or a normal volemic or hypervolemic situation. If you are, then it's quite okay to do it. But if you don't have invasive monitoring and so on, then you might be doing the wrong thing to the wrong patient. So you put yourself at risk, in my view. But if you have a very close surveillance and you see that the patient's central circulation is highly filled, you have the intrathoracic blood volume index is perfect, well, that's something different. But if you have in a resource limited situation where you're not are in control of the volume status, you put yourself at risk, especially when you have a situation where you know that you usually have a hypovolemic period. And also for the group with that come late to your resuscitation, although the science behind how to deal with them are not as strong as for the regular patients, it's well known and it's well considered that they need more fluids, and the risk in using inotrope for those are even larger, I would guess. So therefore I would advise to be very cautious against that. And urine output is an easy measure to obtain and to follow, and one cannot but encourage the frequent and careful use of the urine output measure.
So the strong sense one has from you is that you're supporting Adeline's position to push with crystalloids and to concentrate on replacing volume with crystalloids, but judiciously.
Yes, and the other side of the coin is always when you run into over-resuscitation. And so that's the key issue that you have to be aware of. And if you know that about 300 mils per kilo in 24 hours is a very good cutoff point to be able to guess that will increase compartment syndrome situations. And that has been well documented in patients by the Japanese group who published that first and rather extensive paper in compartment syndromes.
Thanks very much, Folke. Can I just come back to Professor Mughazia, Amir, and just any further views on what's been said from your point of view, Amir?
Yes, I totally agree with them. I'm talking about we have done what is perfect. We have stable blood pressure, we have good pulse, and we still have no urine output sufficient. In this case, we give the inotropes. But if we are still lacking to perfect measures of resuscitation, then we should go also for fluids. Still, we are sure 100% that the patient is not hypovolemic and the problem is a renal problem, not a pre-renal problem.
Thanks very much, Amir. Shoba, may I please ask you, we haven't devoted much attention, although Amir said a lot of very good things about care of children. Anything else you want to say about pediatric resuscitation in the more limited resource setting, Shobha? Any specifics about children's resuscitation and fluid management that you would like to mention?
Well, I have used albumin in pediatric patients much earlier than after 24 hours. I've used it if the patient is not responding to crystalloid regime in 12 hours, then we add albumin to the regime, and we have seen good response in two ways: that the hemodynamic status improves and the child is able to accept oral feeds and retain it, because the edema of the bowel also reduces, I guess, and so acceptance of oral feeds is better. And for pediatric patients, oral rehydration is a very important thing for us. That way we have reduced dependence on intravenous resuscitation. That is all. Albumin is what we introduce, and sodium levels are to be monitored, because we have very often seen hyponatremia and seizures in pediatric patients, not so much in adults. I don't know why.
Could I ask Adeline from South Africa, again, treating many patients there, do you have a greater inclination to use albumin in children's patients, or do you also just mainly use crystalloid in children in Africa?
Yeah, because of cost issues, albumin is quite extensive in low-income country. Though we have access to albumin in South Africa quite easily, but it is not most part of the acute phase resuscitation for burn patient. For children, we concern of especially hypothermia, as it has been mentioned. Even if you give enough fluid and so on, you must make sure that you prevent hypothermia. And the second thing, more important, you prevent hypoglycemia, and that's why you, as you know, into the Parkland formula for children, you must always add the maintenance fluid. And many people do forget that in children, and they end up with hypoglycemia and kills the patient in the acute phase. So yes, albumin may be considered, but it's not a routine use.
Thanks very much, Adeline. So previously we had the mention of the use of continuous dialysis. And Folke was just raising his hand to comment on what Adeline had said. But so, Folke, can I ask you about dialysis for burns patients? And one of the previous panelists had mentioned the value of continuous rather than intermittent dialysis when it's used. And you can answer that and discuss that, but also mention whatever you're raising your hand for, please.
Yes. Regarding dialysis, it has been discussed very much whether you should use continuous or intermittent. And looking at the strong science behind that, there is actually not that much unless you really look into the circulatory severely compromised patient. In that situation, it's easier to perform dialysis and to reduce and let go of water in that situation. But if you have a circulatory stable patient, there is no need not to use intermittent hemodialysis. Previously we used continuous, but now we use intermittent most of the time because the patients are circulatory stable, and the dialysis machine and the predictability and the amount of dialysis that you can perform is much better controlled in the regular dialysis machines. So I would advocate that if you don't have a problem with hypotension, you can as well use intermittent dialysis, and that's more available for more people because they have the cooperation with their dialysis department. Whereas when you have continuous veno-venous, for example, then you need to be trained yourself, you have to have the equipment, and you have to have the volume to be able to defend that you train your staff to perform it. So that's my concern about that. The other topic I would like to touch upon is a little bit what Professor Moghazi and also Shuba was mentioning, and that's the oral rehydration. And I would like to hear your points on adding salt to the oral hydration in children. What's your opinion on that? I would anticipate, especially when you were saying you were having seizures in the children, wouldn't it be a good idea to add salt to the oral resuscitation?
I think that's what Amir said. He said he added salt to his ORS and his formula. Amir, please enlarge on that.
Yes, we do that routinely. We add salt to the ORS either for adults or for children. But in children, we concentrate from the second day on the hyperalimentation with salt supplements also. So salt is more given to children rather than adults.
And I think for the audience, I think it's right to say that Professor Moghazi has published on that and they can refer to that afterwards. Shoba, any further comments to what Professor Moghazi has said about that?
Yes, we do add salt regularly in the feeds for both adults and children. Because of hot weather, there is an issue of sweating in addition. So salt is generally given to both.
Thanks very much, Shoba, and thanks, Foki, for adding emphasis to that important point. Thanks very much. Moving on quickly, in the countries which have huge numbers of burns patients and lesser resources, electrical injury is a huge problem. And Tanvir, can I first ask you to say any special tips for resuscitation of the high voltage electrocution injury that you have in your experience for the audience?
Yeah, actually, during the summer, we have the highest number of electrical burns, and it is actually in the raging for last few years. So in addition to the electric burn directly, there are some additional injuries, actually associated injuries are there. So we actually try to focus on those things also. And number two, we actually start with the Parkland Spongunda with the 4 ml. And for the indwelling catheter, we actually also into the upper limit is 2 ml per kg per hour. The output. And number 3, we actually try to go for straightway for the securing the central venous line. We actually go for the central venous line. And number 4, we have the facilities. So if there is any damage that is regards to be amputated, we straightway try to go for the amputation as early as possible. And for the fasciotomies, if required, we used to go, because most of the limbs, many of the times we are getting so bad limbs, all totally charred. So there is no way other than to go for the early amputation. So in this way, at this moment, we are trying to improving the situation, because if we are able to exclude the dead tissue from the body, so it ultimately improves the outcome. That is our experience.
Thank you very much, Tanvir, for a very succinct and comprehensive answer. Can I just ask Professor Amir Moghazi, do you also go for 2 mils per urine per kilogram per hour urine output in patient with high voltage electrical injury? Is that a similar thing to what you would think about that? And
no, definitely not. For the electrical burns, we prefer to have the urine output in the first at least 3 to 4 hours from 1 to 2 milligram per kilogram per hour. Actually, we start by the Parkland formula, upper limit 4, with the oral. Always we have the oral, and then we can raise it more just to maintain the urine output from 1 to 2 for at least 4 hours. When we are sure that there is no myoglobinuriae or something like that, we can return back to our normal, which is about 0.3 to 0.5 per hour.
Thanks very much, Amir. Adeline Maganza, professor from South Africa, I know you have huge experience in electrical injuries. Anything you want to add to what the colleagues say about that?
Yes. Can you hear me?
Yes, we can. Thank you.
Okay. No, thank you. So we do see many patients with electrical burns. As it has been said that you concern of cardiac problems for those patients. But what we've noticed, majority of those patients will have a cardiac event, will die on the scene. So those who will come to you most likely will survive from a cardiac point of view. So the main concern will be the microbiota, as it has been mentioned. And I totally agree with the previous speaker, colleague, who said that in this particular patient, we don't go for modified Parkland formula. We go for full Parkland formula, which means 4 mils per kilo per hour. And we aim for more than 1 mils per kilo per hour of urine output. So we'll watch, we'll look at urine output, we'll look at potassium on those patients. And then if we see that the urine output is not improving, we may start considering adding some bicarbonate. And in a few patients, as I mentioned, that will add some mannitol. And if that doesn't improve the urine output and the potassium is rising, those are the patients where we believe that early dialysis is very important. And that's where we differ with the nephrologist, because the nephrologist will come and tell you, no, patient is still passing some urine, you must wait until it's totally oliguric and so on. But in our experience, for those patients, we'll just put them on continuous dialysis, and the outcome would be better if you start early dialysis than late. That's what we'll do.
Thanks very much, Professor Muganza. Shoba from Indore, any further comments from your perspective on the high voltage electrical injuries?
In addition to that, I use soda bicarb from the beginning until the urine is clear, completely clear. And we rarely use mannitol. With soda bicarb clearance, we generally achieve this clearance in most of the patients, unless the patient has come late and is already in acute kidney injury. The tubules are blocked, then this cannot help. But otherwise, soda bicarb has been able to clear the myoglobinuria, and we do not do dialysis that early.
Okay, thanks, Shoba. Please may I ask Steve Kahn to come back in at this stage and give us his perspective on any other advice you would offer the audience about high voltage electrocution injury management, particularly from the resuscitation point of view.
Absolutely. You know, I think that something that people always or often omit to is just following the basic algorithm of, you know, managing a trauma patient, ABC, you know, making sure that there's not a traumatic injury, you know, spinal cord fracture, long bone fractures as you're initiating resuscitation. In the United States, most folks have abandoned mannitol and bicarb. Their data is pretty clear that shows there's no benefit. This was based on based on 2 studies, one from 1979 and one from 1984, which is a prospective study of 7 patients. The only time I'll use bicarb in my practice is if the patient shows up and they're woefully acidotic, like a pH of less than 7.2, and the bicarb is very low, and they need it just to maintain their hemodynamics. But otherwise, we're believers in low chloride balanced resuscitation. And the same thing, I want to aim for at least 1 cc per kilo per percent TVSA. I don't want it to be higher, you know, but for those patients with small cutaneous injuries, but terrible muscular injuries in rhabdo, we will, I want them to be making, you know, basically the same amount, and we'll titrate those fluids up and down. But all of the data that's been showing up about normal saline versus balanced low chloride fluid is pretty conclusive in all comers, and most centers have extrapolated that into rhabdo. So we're really avoiding the use of sodium chloride and using Plasma-Lyte and LR really as our mainstays.
Thanks very much. Thank you. So we just have 5 minutes left. So at this stage, I just want to thank all the rest of the panelists, and I'd like to hand over to Volker Sjoberg just to give us any views of his about summing up. Volker, if you could pass back to me at the end so that I can thank all the panelists. But what are any conclusions, Volker, that you have as an internationally respected burns intensivist about what we discussed?
Thank you very much for handing the microphone over to me. And I would like to allude a little bit to Professor Kahn's start because he was showing what has changed over the years in fluid resuscitation. And the answer was, as he showed in his slides, that nothing has changed. And this has been very well adopted by everybody who has been presenting their data. Everybody seemed to be aware of most of the drawbacks of the overfluid resuscitation, and at the same time, the struggle to make sure that you give enough fluid. And even if you come from a high resource country or a very low resource country, the real principles seem to be almost the same. And also the approaches are not that different. One of the things that I acknowledge is the oral hydration approach that is more and more called for in the very resource limited situation. But there is also an important knowledge in that, because it might be that we are in order to do high-tech care, we might overuse the IV thing in the high income countries. So I think that I learned when I hear from the speaker series that you can be very successful in using oral hydration. And I've learned also about the salt additive, which was early anticipated when the Parkland fluid was launched by Charles Baxter. They were very much pronouncing the knowledge around the sodium part in the resuscitation. And this is also underlined by today's speakers when they call upon using fluids which are without minerals, and they add salt to their solution to make and accomplish the same result as we do with intravenous sodium chloride. So that is something that I find very interesting with these presentations. Also, the other topics that have been touched upon, delayed resuscitation, the problems with electrical injuries seem very much to be harmonized, although the possibilities of dealing with them varies depending on where you're localized in the setting. And people seem to be very well aware of the risks that each of these sort of injuries pose on the treatment principle. So I've been very glad to see the very good presentations by the different speakers, and I hope the audience also have the ability to appreciate what has been said, and that the presentations can really convey a good message to everybody that are practicing burn care in both high-tech, high income, and as well as in low and middle income countries. So, and I would like to, before I turn the word over to Stuart, I would just like to thank Stuart and Nadim for actually hosting a meeting like this and making it come true. And I think it's very valuable for everybody, not only for the low income, but also other people, to see that you can accomplish a lot of good results by just staying put on physiology, studying the literature, and being attentive to details. Thank you, and the word is over to you, Stuart.
Thanks very much, Folke. Thank you. So at this stage, I just want to thank charities Be First and Research Africa, British Burns Association, British Association of Plastic Surgeons. I particularly want to thank my colleagues Nadim and Orange Shelley, whose idea it was to start off this series of webinars, and for involving me in that. And also my colleague Jorge, who works with us doing that. And finally, I just want to give a huge thanks to the speakers. I thought we had an absolutely brilliant talk at the start from Steve Kahn. I thought that was a tremendous talk. Adil's talk was also superb, and I'm sorry that he was bedeviled by problems with the sound during it. But for those of you in the audience, there'll be a recording and you can review all his slides. And one of the striking things I think about it, as Folke said, is the consensus about the style of resuscitation that the two lead speakers were advocating, and that the other speakers have been advising as well. So thanks to Steve, to Adeline, to Folke, to Amir, to Shobha, and to Tanvir. And I'm so grateful for them all for joining us. And I really enjoyed this afternoon, and I hope that it was good for the audience as well. So, and thanks also to the audience for joining us from all over the world. And please let your colleagues know that a recording of this will be available. And as I say, with the problems with Adeline's sound, you can review his slides and also review Steve's presentation. Thanks everyone for joining us.
Thanks, Stuart. Just to wrap things up, if I can remind the audience to fill in your feedback, and then you'll get your certificate in a couple of weeks. I'll have a chat with Professor Maganza, see if there's a possibility of us recording, if he can spare 10 minutes to record his talk with the audio, and then we'll perhaps put that on the website, possibly. And any other protocols that people have been requesting, we'll put those on the website as well. It usually takes a couple of weeks, so bear with us, please. And thank you very much, and look after yourselves. Take care. Thanks, everybody.